Welcome to the Health Leader Forge. My name is Mark Bonica, and I'm a professor of health management and policy here at the University of New Hampshire and the host of the podcast. Today is a special milestone for this podcast. This is our 50th interview. We've been doing this podcast for a little over 2 years, and I've learned so much from the guests, and I hope you have too. I'm very pleased to have today's guest, Richard Silveria, as our 50th interview. Rich is the Senior Vice President for Finance and the Chief Financial Officer for Boston Medical Center. Boston Medical Center is a safety net hospital with roughly 80% of its $1.2 billion in revenues coming from Medicare and Medicaid. In addition to being a safety net hospital, it is an academic teaching hospital associated with Boston University's medical school. Rich has been the Chief Financial Officer since 2010. During his tenure, he helped engineer a financial turnaround of the organization and continues to strive to be a leader focused on driving change. In this podcast, we trace Rich's career from a start in biology and education through computer programming and financial systems to today, where he is a senior leader in the third largest health system in Massachusetts. I want to say thank you to the College of Health and Human Services and the Northern New England Association of Healthcare Executives for their ongoing support of the Health Leader Forge. If you find this podcast valuable, would you please rate us and leave feedback? It helps people discover us. Also, feel free to share the podcast with your colleagues as well. Thanks for listening, and here is Richard Silveria, Chief Financial Officer for Boston Medical Center. Welcome to the Forge, Rich.
I'm glad to be here.
So you earned a Bachelor of Science in Education from the University of Massachusetts at Lowell.
Yes.
What drew you to UMass and why education? How did that come about?
So Lowell is right in my backyard. I was in Billerica at the time. I was considering medical school at the time, and I applied to a few schools. I applied to BC was one of them, BU. And I got in, but my dad, being conservative, he came up through the ranks, was in Korea and did some training for like hotel and restaurant management. Very conservative in terms of like, well, why would you go to BC and spend this much?
Yeah.
Versus you can go to UMass, or at the time it was University of Lowell, and it was Lowell Tech, and he said you won't have as much debt, and you have a bio degree, and then go on. Yeah. So I did that, and it was a good school. I went to Northeastern later, and I look at the quality of the professors that I had. They were great. So I started taking science, and then I started taking other classes. I took a couple of computer programming classes that I kind of liked the logical puzzle. And I took an accounting class. So a friend of mine was going to be a CPA. And I said, I ought to try it. My sisters were nurses. I had two sisters that were nurses. And I always did really well in science. So I said, well, let me try it. And I found out that I liked it. And so I said, well, why don't I finish this degree, get some education? So I had health, but I could also teach general science, biology, and chemistry, in the state of Massachusetts at the time. Okay. So that's how that was my journey through college, anyways.
So, and that I saw your first job. It looks like out of college was at Choate Sims.
Yes,
Choate Sims.
Choate Sims. Yeah. Okay. And they are no longer. But they were a community hospital network, Choate Hospital in Woburn, Sims Hospital in Arlington, and there was a health center in Wilmington. I actually got that job. I just kind of beat the pavement, and sent resumes everywhere. Could have papered my house with rejection letters. But I got a job initially. My first job for the first few months was actually doing health promotion, teaching classes as part of their public relations department. Okay. It was only a few months. I didn't put on my resume, but that was great. It actually leveraged my science background. It got me into healthcare, which I knew I wanted to be in healthcare. I was interested in healthcare, and I saw it as a large economy here regionally. And I wanted to give back to society, and so I figured, well, I want to do business, but I want to do it in healthcare. Okay. And so I started there, and then an IT job opened up. So that's how I got into systems from there. Okay. So you moved from education to IT. Yeah. How did you make the move from? And what were you doing in IT at the time? So I had taken a number of numerous computer programming classes, as both while I was at Lowell, and then I also took night school, and I started to round out to prepare for an MBA. And at the time, I wasn't sure whether or not I actually wanted to pursue information systems and computer science. It was math at the time but it was, computer science was an emerging field. And so I had all that training, and they had an opening for a financial systems person. And I had started my MBA, and they said, well, why don't we'll give. So some of it's luck, right? So you apply, you're there. They know you as a hard worker, as someone who could present themselves reasonably well. I could speak. I taught, but they were taking a chance on me in terms of, am I going to be effective in IT? And then the luck part of it is, at any time when you apply for a job, you don't know what the pool of candidates are going to be, right? So that's probably the fortunate part, is that I competed pretty well with whoever applied for that job at the time, and I was lucky enough to land it. And then I just went at it doggedly and tried to learn as much as I could, and that was always been my approach, is to when I was in school was get the A. And then, you get your job, you just want to, that same work ethic just continued.
So you were in financial systems. So it was IT, finance and IT together? Yeah.
So what I did is, believe it or not, it was the 80s, and there was a paper general ledger.
Okay.
And so we built a general ledger. Not all of it was paper, but parts of it were. We did accounts payable, payroll, set up the revenue cycle system, so the billing systems, which are fairly complicated. I also had the opportunity to do some things that were not entirely financial, but they were quasi-clinical, where you would order a lab from the floor. So the nurse might order a lab from the floor, and a requisition would print in the laboratory, and the phlebotomist would go up to the floor, and you had to make decisions to charge on order or charge on results. And so order entry was called order communications at the time, before they had electronic health records. So it was a great opportunity for me. And DRGs and groupers and case weights and things like that all came out at the time. So I remember building out the DRG tables. And so it was just a great, confluence of IT, but also I got to learn how the financial systems kind of hung together from a transaction perspective. And I could also see from a data flow, when a patient comes in and they're registered and they're interviewed, and how that data then goes into the system, and then how that data then cascades to the pharmacy systems and the lab systems and says, hey, Rich Silveria is here. And then when you go down there, you don't have to re-register them, and then the charges hit that particular account. So it was a great opportunity to just kind of, through the way the data flowed, you could make inferences about how the chronology of the care process worked. So it was a great experience. I really enjoyed it, but I was going for an MBA, and that's why I didn't stay in IT.
Okay, so you were you eventually were the financial systems manager.
Yes.
So what was that role like?
That was really I oversaw all the financial systems. So I had the general ledger. So I had to be able to interface with the accounting department and research why the system didn't work, or set up new cost centers, or debit and credit accounts, automate them, accounts payable, payroll, in the billing system. So initially it started out as an analyst, but then I oversaw a small team. It was a small place, but I had 2 staff, and some of them were working on interfaces, or it was a timeshare system. So a timeshare means that you actually send in jobs in batch.
Okay.
And so you do your payroll, and the payroll runs in batch, and then you get exception reports. Okay, well this pay type didn't work, or this person had an invalid number, or whatever, and you'd have to fix the error. So I had people who would fix batch errors and make sure that they stayed in sync, and that tied to the general ledger, et cetera. And then similarly, you'd run scheduling the billing jobs for the various payers, Blue Cross, Tufts, Harvard, Blue Cross, and then making sure that the payments were posted and they tied out to the GL. So a lot of it was transactional, but some of it was also making sure that the systems interoperated, that when a charge came across, you had a GL number that it would point to, and it would post automatically to the general ledger. So, but I had a small team. One person would kind of help me configure the system and run reports. I also wrote reports. and another person would do more of the clerical, kind of the batch jobs or interface work. And it was the beginnings of micro PCs.
Yeah.
So it was really quite innovative when you downloaded data from a green bar report. So your students listening now is like, what is a green bar and what's a dot matrix printer?
This is true.
Right? And so, in fact, you would, when you had spreadsheets, you'd have 132 characters. You'd actually turn it sideways, and you had software called Sideways, and it would print the schedule sideways so you could fit all your rows or your financial statements on it. But we used to take the data and have delimited data. So you probably see that in Excel, where you have date or numeric or alphanumeric, and you have your data types, and you download it into it was Lotus at the time, or VisiCalc even before that, and then into relational databases like Paradox was one back in those days. So wow. It wasn't all Microsoft Office back then.
Right. You left Choate Sims and moved on to Lawrence General in 1988.
Yeah.
What kind of spurred the move at the time?
So, I had done a little over 5 years at Choate Sims. I just want to one experience I had at Choate that I thought was a good experience for me. I was going for my MBA, as I said, and I had come back from my quantitative analysis class. And I was in there with a lot of engineers. I was at Northeastern.
Okay.
And a lot of them, I took calculus, but I wasn't, I was an expert. These guys were experts. And they only had to learn one basic formula, and they would derive the rest. So I had all these things in my head. And I aced it. I came back to work, and I told my boss, and said, I feel great. I know I just aced that. And to which they said, and I was one of the better employees, and said, well, why don't you get an A in your job, right?
Oh.
So it's like, well, that was a rather crass comment. You walk away like, that was not very nice. But then I thought about it, and I said, that's probably some pretty good advice, because what am I willing to do? So I went at night. Uh-huh. So what was I willing to do to get that A? I was, so you're in your 20s. You go to your cookout or whatever, you say, well, I can't only stay an hour. I got to get home. I got to study or whatever. And I started thinking, well, why don't I get an A in my job? You know? And so that was one of and I'm going to talk about another one in Lawrence, but that was kind of a defining kind of career, kind of snide remark, but kind of a kick in the pants a bit, and said, well, if I really do want to be influential and make an impact on an organization, you probably can't do it as a C player. And so that was one of just in terms of sharing something that happened to me with your students, it's like, if you're willing to do that, and you get up early and you're tired at night and you'll study at 4 a.m. to get ready for your test, we all been there. So if you had to do that, I didn't do it at the same intensity, I will admit, but I did bring, books home and learn about DRG systems and things like, well, why don't I understand so I can support this person over there differently? And that was kind of a defining moment for me. So I left Choate Sims because I had an opportunity then to segue into finance. And it was kind of hard to get into finance without having finance. I didn't have the degree yet either.
Okay.
So Lawrence General was actually a Boston Globe ad. So Choate Sims was a cold call, just persistence. Lawrence General, I answered a Globe ad. And I got interviewed, and they said, well, you don't have, your finance degree, you've never done it before, but, we'll teach you. And part of the reason they took the chance on me is because they had just gone through a system conversion, a data system conversion to a new billing system, and it wasn't going well.
Okay.
And they said, well, why don't you, help us kind of turn this system around, and we'll teach you finance. So at the time, that was 1988. I was 28 years old, and my wife was pregnant with my second daughter, and so I started there on Halloween. So I showed
fortuitous day to start
exactly,
a job.
Ominous. And but it ended up being one of the best things that ever happened to me. So I got there, and the first day I went in there, literally the first day, they sent me into Boston to pick up a check for $600,000. So because our state senator Pat McGovern had helped us to get that, because we were having difficulty getting claims out of the system, so there wasn't cash coming in. And when I was researching, I was a kid, so I wasn't really well networked, but they said, well, they just did the turnover, new CEO, new COO, new CFO. They're looking to kind of turn this place around. So I thought, hey, this is a great opportunity. And it ended up being it, but it really tested my mettle because after that, within a couple of weeks, they were in front of the acute care conversion board.
Okay.
To either convert it to something else or potentially close the hospital because they were having so much financial difficulty. And so within 6 months that I was there, pretty much everyone really everybody who recruited me there was gone. The one people that were going to teach me. And I remember the CFO talking to me about, him going to the board, and we were looking at, the cash coming in and looking at making payroll and just grinding it out day after day. And they say, who is this guy that's going to turn around this business office? Because it was accounts receivable that I started in. And basically they said, who else is going to come here, right? It was the best thing that ever happened because people from Choate were calling me, say the bricks are shaking out of the mortar. You want to come back? And I just didn't want to do it. But at the same time, my wife's, in fact, one of the, because I was in the claims area, they would look up eligibility online in Blue Cross to see, does this person have, benefits, and do they have a valid insurance contract? And like week 2, someone said, well, we haven't paid our insurance. We have no insurance coverage, So, when you're a kid and you hear all that, and for whatever reason, I just said, look, I'm just gonna take it one day at a time, and I just basically try to understand what the issues were, and try to categorize them by type of issue, and then kind of prioritize them in terms of criticality. And my style in the approach working with these people that I'd never done it before is what I found kind of when I was in Northeastern. I took a class and they used the Harvard business case study approach, and management by walking around, ask questions and those kinds of things. That kind of stuck with me. And so I would ask people, they would come to me with questions, and if I wasn't familiar, which frequently I wasn't, I would say, well, tell me your experience here and what would you do? And I would gather data, and it was kind of surprising. The benefit was that they were surprised I was asking them, but there was also like, wow, my opinion matters, so you have an engaged employee. And then I would just kind of graph things together. Well, what if we kind of I was thinking this, but that's a good idea, and I'd modify my thought. And we just doggedly worked through the issues in terms of criticality and slowly over time turn the place around. So that's a long digression, but that's one of my earlier, and that was probably in my career. That was probably my defining moment in terms of the inflection point that got me to where I am.
In terms of commitment to finance,
in terms of commitment to finance, and in terms of developing credibility as a performer.
Okay.
That I stuck with it then. And I was there 10 years, but we went from over 150 days in accounts receivable. So a day in receivable is, let's say that you sell washing machines, but you don't sell it as a retail. You bill them later and say they're $1,000 each. If you have $5,000 in receivables, you have 5 days in receivable. We had almost 160 days in receivable, and it's a high Medicaid. So Medicaid, because the state tends to pay slower because
right.
the state has its financial challenges. But we got it in the 60s in a couple of days and maintained it. And then I took on other functions at Lawrence that you'll talk about. But to me, that was, there's to be able to kind of doggedly go through that and kind of see the issues and try to focus on them in terms of criticality, which is going to be the most impactful thing in terms of turning around the receivable and getting cash in here, and then trying to work through people in an area where you really didn't know what you're talking about. That was probably the best training of my life.
So how many people were you supervising when you first got there?
About 50.
About 50. Wow.
Yeah. So I went from 2 to 50.
Right, I was going to say, your initial job,
yeah.
So going from 2 to 50. So what did you learn as a supervisor? So you kind of talked about engagement. What were what were some of the lessons that you learned at that point that you have stuck with you?
Yeah. So one of the things I some of it was through my learning, and just like your students are, I've always felt like nobody knows their job probably better than the person who does it every day. And I don't pretend to know everything. So I would ask a lot of questions. So the first thing, I guess, is kind of like you learn in kindergarten, right? The golden rule, right? And so I try to treat people with respect, and I try to treat them the way I'd want to be treated. And so that's kind of the baseline thing. And you be professional and you be assertive. You tell people, they come to you with their problems, and you try to help them. But if I'm solving their problems all the time, then we got a different problem. So I would try to be honest, but balanced, and I would try to engage them. But if they were not doing their work, or complaining about so and so or whatever, I would just tell them, look, you need to focus on what you're doing. I'll deal with them, and try to just set boundaries with people, and then they respect you because they're going to test you, especially as a kid. You're 28 years old, and some of these people who listen to this probably aren't 28 yet, but I still feel like you were a kid at that point, and these people are in their 50s, et cetera, and they've got a few more years of experience than I did. But what I try to do is just be fair and just ask them questions, respect them, thank them, but really almost immediately just make sure that you set the tone that, yes, I want to have a collegial conversation. I want you to be approachable. I don't believe in the authoritarian. I think that's probably the old-fashioned style of command and control, but more as a teammate.
Yeah.
But a teammate that is also kind of the coach. And so I would always tell people what I expected of them. And then when they didn't deliver what they expected of them, I would be respectful and say, come on in, let's talk. And I said, you gave me this. This is what I thought I asked you for. This is what good would look like to me. So can you come back with what I would expect for good? And then they would, and you don't accept, because then you one thing you have to realize early on when you go from 2 people manager, that you could probably carry 2 people if you work harder. There is no way you're going to do the work of 50 people.
Right.
So you have to learn that very quickly, and you're standing on that. You're only as good as the people that you work with, and you're standing on their shoulders. And so what I found is I did not have to fire. I had to fire only one person because of a behavioral issue. I didn't like doing it because you look at people and you see car payments and kids and mortgages and things, and you feel for it. Sometimes you have to do it. But I was able to kind of get the people to the next level of performance by one, the style, and then quickly I would try to, because finance is highly measurable. So days in receivable, claims over 90 days, cash collections for the month. And I would put up charts and graphs and say, we did this month, let's make this the goal. Warmish General is not it still isn't, it's not a wealthy hospital. But I was able to say, look at, we're gonna do a pizza party, or we're gonna do something, just something, casual, and say thank you. I would have loved to do an incentive comp plan, but we just didn't have the resources to do that. But people appreciated. I thought that they thought it was fun, and it just the going around and saying, that was a great month and thank you, and some of them in their 10 years, and they maybe didn't know how good they were doing because their world ended at their cubicle. And you try to connect it to the larger ecosystem of the department in terms of claims going out, cash coming in, deposits to posting, so that you post it, it goes to the patient or the next payer. It all is connected. Try to get them to understand that. And then try to broader vision is, cash is the lifeblood of this hospital, and this hospital saves people's lives. And they're just, I'm just a biller. I'm like, no, actually you're not. What you do is important.
Yeah. And
so that has worked, that approach has worked in all my jobs. If you try to connect it to the broader, the broader objective, you're not for-profit, whatever the broader objective and strategy, and that what they do connects to that and get them excited about it. It's hard over years to do that. Yeah. Because people get tired, and your company inevitably goes through performance troughs, but you have to be, vigilant about it. And I think you have to walk the walk and talk the talk. You got to be fair, and you've got to be forthright. And even if you have to deliver a message that's not sugary sweet, you got to figure out a way to tell them, and at least respect you. They might not like the message you have to give them, but they're not going to go back and say, well, you misrepresented. Yeah. And so that's how I approached it. And that's how I think it worked out.
I wanted to ask you, so you finished up your MBA while you were at Lawrence General with a focus in finance at Northeastern, as you mentioned. What made you decide to choose the MBA as opposed to, say, an MHA?
Well, that's a good question. I also thought about an MPH.
Okay.
And I thought that with my science background and the other things that I had done outside, was an EMT for a while.
Oh, really?
Yeah, and as a kid, I was a lifeguard, and I trained as a ski patrol. I never really did much of it, but a friend of mine did it. I did that. So I said, I had advanced first aid. I said, well, and I take, an EMT course. So I did. I kept it up for a few years. I didn't do a lot of it, but I thought I had a lot of health background already. I didn't have business background. I didn't have like a business, and I wasn't quite sure what I wanted to do with it, other than I wanted to have progressively more important or more significant roles that could impact the outcomes for an organization. That was kind of my direction.
Okay.
I wanted to get in a position where what I did actually had a meaningful impact on the performance of the organization. I didn't know I was going to end up as a CFO.
Yeah.
But I thought that, hey, you can always find work in business. I've already kind of with a health degree. Would I round myself out more with an MBA? And that was the reason I did it.
So I was wondering, was it that you saw yourself at that point as a finance professional, as just a manager, or were you really committed to healthcare at that point? So it sounds like maybe you were leaving yourself open a little bit to leave the industry.
A little bit open on healthcare, although emotionally I was healthcare.
Okay.
I was just but if something happened, could I do something else, right? Just kind of maybe a safeguard. When I did the IT, it kind of solidified I liked the puzzle of finance, the balance sheet, the financial side, but also kind of the data flow and how it worked. And I said, well, I wouldn't mind, overseeing those areas, rather than create the pipes that support those areas and the data. And that skill set combined really helped me because then I could talk to the IT. When I first started at Lawrence, they actually had me in there. I was working in the system.
Yeah.
Other places, they usually have more hygiene around, who can configure a system and who can. That's appropriate. But I liked the kind of the rigor of finance. It's somewhat, I didn't really like, I was a finance major, not an accounting major.
Okay.
I like the creativity of the functions of the dollar. The debits and credits were too regimented for me, but I like to be, future value, net present value, internal rate of return. So I like that creativity.
What do you see as the difference between finance and accounting?
I think
you're talking about it.
Yeah, somewhat. The difference really is, I think the accounting is highly technical. There's the generally accepted accounting principles, there's FAS, there's GAAP. So there's definitely a framework and rules, et cetera. And but the thing about it, you need to know enough about it because it is the language of business.
Right.
And so you need to be able to read, an income statement and a balance sheet and changes of cash flow and those kinds of things. But I think, I don't know that I could sit at a desk and do debits and credits all day. And I knew that.
Yeah.
But I always, when I took like real estate finance and, it was the early days of, puts and calls. They didn't really have, swaptions and derivatives and hedge funds and all that. That was still to come. I thought that was kind of fascinating, doing the net present value and doing, valuations. And so I liked it. And so I just said, I'm going to do my finance major. I'm going to do business. I got business, but because I just thought it was more creative. And I guess the difference is accountants kind of keep the score and tell you where you're going. Sometimes where you've been. And whereas finance, sometimes you'd look at a business case, you'd look at the future revenue, you'd look at the costs, you'd net it down. These are the future cash flows. You discount it back based upon a certain targeted rate. Maybe it's your weighted average cost of capital, and you have to have a certain hurdle rate. And to me, that's like, does this business case make sense or not? To me, that was way more exciting than. But everyone's different, and I've got some great accountants, and I couldn't do my job without them, and so you need them. And some of them challenge you too with those, the accounting rules. I was just more excited with finance.
So you started out at Lawrence General as the Director of Patient Financial Services. You did that for about 5 years, and then you were promoted to Director of Payment Systems, and then ultimately Vice President of Managed Care.
Right.
Can you talk about those other roles?
Yeah, so actually, part of the reason I was promoted is that I'd been there 5 years. I was approached by, actually it was University Hospital right next door here.
Okay.
But it was a bigger, teaching hospital, same kind of role. And I talked to my boss about it. I said, look, I could go into Boston and, get some Boston experience and spread my wings a little. And I had done a good job. And I was fortunate that he said, why don't we grow your career here? Why don't I give you some of the reimbursements? So there's, Medicare cost reports and things, kind of setting the prices for our gross pricing. Start to do risk contracts and managed care contracts. So risk contracts is where you accept insurance risk. You get a premium, and you have to kind of project your utilization and your pricing, and you look at things of site of care. There's rate differentials if you went to Lawrence General, for instance, versus a downtown Boston hospital might be more expensive. So I started to get into the reimbursement and managed care space, and I did that for a couple of years. But he told me at the time that I didn't go to Boston that he'd grow my career, and there was some other things I did there, like we stood up a home care company, and I set up the billing systems and the intake systems because so I had parts of IT because I had that. We had some physician practices that we're acquiring. Okay. And I would kind of oversee those and set up the systems there. And there was a director of accounting at the time, would be working on the deal, and I would be on the team, but more on the periphery. But then ultimately, a lot of that I owned it.
You owned the transaction?
Not so much the transaction, but the oversight and management of it, So the transaction was probably more the CFO.
Okay.
And then as they came in, although I was involved, we had engaged some not accounting firms, some consulting firms that would help us do the valuations. So I was involved in that. But I wasn't driving the transaction itself.
But you owned the management of the...
Yeah.
Oh, okay.
So like the people who would manage the practices would report to me.
Wow.
And when we created a women's health radiology center, we had a couple of primary care practices. We had a surgery center. We had the home health. So, Lawrence General at the time was maybe $125 million. It's a smaller place compared to when I went to Partners, which was over $4 billion.
Right.
But it was great because I had kind of the revenue cycle, the front, middle, back of revenue cycle, which means like, coding and the registration, admitting and the billing and the pricing and the charge capture, managed care, parts of a health system, the practices and some of the outside ancillary areas and parts of IT.
So you were actually supervising the practice managers at that point?
Yeah.
Wow.
I also had a what they called a prenatal clinic, which was, it was also kind of eye-opening too. It was just, you got a real good view into inner city life and people who struggle. Yeah. And so I would be managing this, and this, it was a very altruistic physician woman who would take care of, young women who were expecting, and trying to guide them through that kind of it happens, with poverty and not being educated, and so so I'd learn about, the reimbursement rules around delivery. You'd learn about new innovations in contraception and things. It was kind of, so I'd figure out the reimbursement about a Norplan implant that was a long-term, so I would research the reimbursement rules, set up the charges, set up the systems, and I also oversaw that clinic. So, and you also got a good lens and actually see the face of poverty, which was, to me, kind of inspiring in a way that I was doing something to help some people, so that was reaffirming to me.
Helped set up the Lawrence General Physician hospital organization.
Yeah.
What is a PHO, physician hospital organization?
You hear the saying, if you've seen one, you've seen one, right?
Okay.
But basically, a physician hospital organization is fundamentally capitalized by the hospital. So there's so you're putting in money and you are trying to bind independent physicians, typically in a community hospital context. They're not part of an academic medical center where they have their offices here. They're out, all over the community, Methuen, Salem, New Hampshire, Haverhill, Mass, if you're familiar with the area. And you're trying to create a contracting entity. So one is you face the payers as a collective bargaining unit almost.
Okay.
And hopefully that's enough market clout to get preferential rates. But the whole notion is that you're going to emphasize primary care, which is still what we're after now, after the Accountable Care Act. This is the 1990s. Prevention, and ultimately take on insurance risk. In the 1990s, you didn't have electronic health records. So you went from, I'm going to get paid based upon what I charge, largely, to I'm going to take full insurance risk.
Right.
With no tools. And you might recall the Helen Hunt movie about, HMOs in the 1990s. I think they used the term, that my damn HMO. They started to get disparaged because they would deny care, et cetera. And so it was before, they also had quality measures in terms of immunization rates, well baby visits, those kinds of things. So you really didn't have any measures of quality, nor did you have kind of the electronic data to really understand what kind of a population you were managing.
Yeah.
And you fast forward to today, you have electronic health records that have problem lists. So, I have diabetes, or I have asthma, I have these allergies, I take these drugs, and these are my recent results. So that's the provider, and hopefully you share that in a network. And then you have the incidence of claims data. So you might have a diabetic, but then you look at the claims data and you say, I don't see a lot of incidents, so they must be managing their diabetes. But I have this diabetic who also has hypertension, and they're frequently in the emergency room. So you start to create care pathways in medical homes where you say, I'm going to engage this patient and help them manage their situation. So, but a physician hospital organization still persists today. It might be called an accountable care organization. And again, like I said, if you've seen one PHO, you've seen one probably the same with an accountable care, but it's very much the same. It's kind of the confluence of physicians, and sometimes it's hospitals, but sometimes it's in partners. They'll have the continuum of care. They have skilled nursing facilities, home health, et cetera, in their accountable care organization. But the whole notion of PHOs or IPAs or ACOs is one, I kind of I'm economically integrated so that I can contract as a single entity and not violate antitrust because I have enough economic or risk integration. And the other part of it is that I'm going to change the way I manage care. And that's essentially what a PHO is and an ACO is.
So in 1998, you left Lawrence General after about 10 years, and you moved to Partners Healthcare System to be the corporate director of revenue finance. So for listeners outside of New England, what is Partners?
So Partners Healthcare is the parent of essentially the four initial institutions, with Mass General and Brigham fairly the two big ones. And then you had Spalding, which is a rehab, and McLean, which is a psych hospital. Those were the four principals. Spalding and McLean were largely aligned with Mass General, and then Brigham over in the Longwood area of Boston, where Beth Israel and others are Harvard hospitals, all Harvard hospitals, came together in 1994 to form a healthcare system. And then they started to negotiate with payers as a healthcare system. They had their physician organizations, academic physician organizations tied to the Mass General, so the MGPO, Mass General Physician Organization, and the Brigham and Women's Physician Organization. And then Partners was, the corporate parent, but it was also a management services organization in that they would look for, anytime you merge, you look for synergies, which is efficiencies. And so what kind of leverage can we get if we get scale on back office things like accountants. Do I need a separate accounting? Or if I just say, look, if I just have a couple more accountants, I can probably pull in other facilities and not have to build a whole accounting department. Similarly with legal, patient accounting, billing, all the kind of real estate facilities, those kinds of things. And so then partners came together, and they initially kind of the degrees of integration are, well, let's leverage space. So we're going to have common space, and we're going to have common management. But then you have disparate systems. And so you have to have somebody who knows how to enter, account payable invoices into the Mass General system versus the Brigham had a homegrown system. And so over time, to try to become progressively more homogeneous in your systems approach to get greater leverage and scale. And, we were still on that journey when I left in 2010. But, that is, so, partners would then say, well, let's try to come up with corporate standards on, reserve policies, for instance, or come together in terms of how we approach Blue Cross in a negotiation. What would be our objective in this negotiation? So you start to have like corporate approaches to things, corporate approaches to supply chain and vendors, corporate approaches to accounting conventions, and the way you roll up your P&L and your balance sheet. So, everyone has, when you're in your own company, you have the discretion to make some, nuanced approaches based upon your company. When you come together, it was kind of the progressive homogeneity agenda.
Okay.
So that's really what it was.
So you stepped in to manage revenue finance. What is revenue finance?
That's a good question. So revenue finance was really all things related to the top half of the P&L. So what my role was, I had, so Medicare and the state have something called a cost report that you have to file. It was more relevant when you were reimbursed based on costs, but it still had things like organ acquisition costs that they settle on costs, residents and interns, those kinds of things are still relevant. So I oversaw the reimbursement function, which is fundamentally cost reports. And they would also set prices, gross prices, charges. I would oversee kind of contract modeling and support the contract function. I didn't have the contract function at Partners. I did have it at Lawrence General, but we would model the contracts, and we would model whether or not we got paid right from the insurers. So you would model them, and then as payments came in, you'd validate that you got paid right. All the billing functions, so for Mass General, the Brigham, Spalding, McLean, and we grew up to North Shore and Newton Wellesley and the Cape. And so over time, starting with, maybe 5 or 6 entities, by the time I left, we had about 12. And so you would, as you brought hospitals into the corporation, you'd have to, do post-merger integration work and bring them in and say, this is how we know. But sometimes doing it with common systems, like we had a common GL, but many times with disparate systems because you had different revenue cycle systems.
So was your goal to eventually migrate everybody to the same system? Yeah,
that's what I was doing. When you'll get to it later on the Compass project, I was working on that.
Okay.
So, it was basically, setting prices, reserves, meaning you might look at a hospital P&L, you'll see gross patient service revenue, less allowance for contractual allowances or allowances for, doubtful accounts. So I would have to, because basically when you get to net patient service revenue, that's basically cash. You have to estimate what cash is because that's going to cover the bottom of your P&L, all your expenses. And, you're at billions of dollars. If you're like, well, on $1 billion here, you're off 1%, that's $10 million, right? So you're just off a little bit.
That's a lot of jobs.
It's a lot of jobs. And so I remember my boss, Peter Markell at the time, said, Rich, I don't want you to be overly conservative because that's jobs, and I don't want you to be overly aggressive because when we overstate income, just be right. And it's kind of amusing, but he's right. And so but you had a lot of complicated, because you'd have deductions would be denied claims because you didn't get an authorization or referral. You'd have a a bad debt, either on a pure self-pay or a deductible after insurance. You have contractual allowances, so you have to kind of estimate, and you have DRGs and bundles, and sometimes the payers would say, well, this is a coding, I'm going to bundle these things together. And so you're doing the best you can. It's not like you're running a sales tape at a cash register and say that was your sales for the day. You're estimating revenue. So really, I would take from the P&L perspective, take gross to net, and then put the reserves on the balance sheet, and then offset the losses as they came through. So that was probably the biggest part of my job, the reimbursement, and then all the contract modeling. And then we also, at the time when I first started there, did a lot of research. We did the indirect cost recoveries and fringe recoveries to support really a fantastic research enterprise at Partners.
So you came from Lawrence, which you said, I believe, was 125 million in revenues, to Partners, which was...
It was over $4 billion when I started. When I left, it was almost $9 billion.
So what was that like?
So it was I would tell you, I was a VP, so I was a big fish at a small pond. And then, so, I had...
At Lawrence.
At Lawrence, yes, at Lawrence, thank you. And then when I went to Partners, it wasn't a VP role, but it was a corporate director role. So I was... I think probably from a responsibility, I probably had more responsibility than at Lawrence. But that, I got to admit, it was hard, kind of maybe psychologically, for lack of a better characterization, for me to kind of get my head around it. But because I scraped and clawed, I got to a VP by the time I was 36 at Lawrence, and I was 38 here and corporate director. But the work was, and it was narrower. I had IPA, PHO. I had those satellite entities. I had the OB clinic. I had parts of IT. I wore 1,000 hats.
Yeah.
And that's probably why I was able to go from a small place to that place, is because I knew how healthcare worked. When you come into like a place like Partners, I can't imagine being an analyst coming into Partners in revenue finance. How does healthcare work? You're in Charlestown in a cube. You're not in and so was fortunate enough to start at a small place in a role where I saw how it worked.
Yeah.
And
you throughout your career, you were kind of very much in the weeds. Right all the way
always
from the beginning.
From the beginning,
gives you a good sense of how the business works.
How it works.
Yeah.
And it was great training. And I don't know if I had worked at a small place like Lawrence General and had a smaller role, whether I would be able to position. And I'll tell you how I got the Partners job. I spoke at an HFMA. So one of the things you want to be in your career, get active in your professional organizations, because you never know. And like I said, I enjoyed teaching. I had a teaching certificate. I did. So they would ask me to speak, and I'd like it, and I'd do it. And so after that, one of the people in the crowd said, "Who's that guy?" And I got a call from Partners.
Wow. Okay.
And so that was, that person talked to one person who called Partners. So it was all because I was involved in HFMA. So you never know what's going to happen. And I stayed there over 10 years. So it was a little disorienting to have such a large swath of responsibility to go a very deep and narrower, but it was very challenging. The thing that was probably different immediately, and I said this to one of my colleagues and he laughed, but I said to him one day, I said, I never worked so hard to accomplish so little. and he laughed. And I said, well, I'm so used to being able to go at Lawrence and make a couple of changes, and you could see the system worked or whatever. It's like you're turning a PT boat.
Right.
And here, I had to learn that you had to talk. There were so many constituents to consider, and so I was in a small pond. I didn't, you're moving probably a couple of battleships,
right.
and you had to talk about the approach to work more than doing the work. Almost, how do you want to approach it? Are you aligned with how we approach it? And then do it. And that's why one of my earlier revelations is, really an influence model, because you had local finance departments. I reported to the system CFO, who all the CFOs of all of the hospitals reported to that CFO, as well as to their local board and local CEO. So they all had their local finance committees. So I had one boss, but I had to quickly realize that I had 8 or 9 bosses, because in some ways I'd be saying, look, I want to set the reserve policies this way. And so many ways I would have to do that for my boss, the corporate person who wanted to set corporate policy. But at the same time, have to turn to the people I was setting policy and say, how's the service in terms of your cost reports and everything else? So you had to, it was almost a situational hierarchy. Yeah, but the style that I took was just to ask questions, acknowledge if I'm uncomfortable about this. And what you find is that, people are uncomfortable if they're just not aware of what's going on. It's so much activity. I'm busy on other things. And so I had to learn to really up my game on checking in on people, listening, which I wasn't always really good at. I had to learn to do that better, because my mind kind of goes fast, and people would call me a box jumper. I'd know where you were going, and I'd be talking where they were going. And they were like, what are you talking about? Yeah. And, I'm talking about Z. Well, I'm still at B. Yeah, but you're going here. It was somewhat, and so I learned a lot of that about the way my brain works and the way others work. So some people are more sequential thinkers, and I could kind of know where you're going, and I'll start talking about where you're going, and they're not with you. So it was from a complexity and kind of being more self-aware of the way your brain works and others, and trying to work in a large organization and celebrating victories that are maybe smaller in terms of what you did, but who you did it with was much bigger. And you had to calibrate that quite a bit. And it's a complicated organization. You've got the corporate structure and its kind of ecosystem in politics. You've got each of those entities with their own medical staff, and they're proud and they're great organizations, and their kind of local flora and fauna. You've got the medical school, Harvard. Yeah. You've got the research enterprise, the teaching enterprise. Fascinating kind of organization to try to figure out how to navigate in.
So you also held simultaneously for a period of years executive director of the Compass program, which you kind of alluded to a minute ago. What was that?
So I described earlier that they were all on separate information systems. And in this case, it was more the patient administrative system. So when you go to the doctor and you go to the hospital and they ask you where you live and what's your insurance, you can see them typing in, and that's a registration system. Tied to that is, where they enter your diagnosis and where they enter the charges, like the X-ray and the complete blood count, et cetera. And then that ultimately goes out as a claim to the insurance. And then once the insurance pays, it goes out as a statement to you for the $20 or $50 or $100, whatever you owe after the insurance pays. They were all on separate systems, all had separate processes, and the physicians had their own systems. And we were looking to by the way, physician compensation is tied to how much they collect, right? So you're taking a lot of organizational change risk in that we all do it, and we all might do it well, but we all do it differently. So it's not like when you if you went to a Ritz-Carlton, you kind of expect what to expect at a Ritz-Carlton. You come to partners, they're great organizations, but they all approached it slightly differently. And so can we have a consistent patient experience and a consistent system? It wasn't just a system, it's kind of people in terms of what you do, the process, how you do it, and technology, what you do it with, right? And so that was what we were doing, and you're dealing with, I've always done it this way, et cetera. Yeah. So I was trying to drive, an initiative to kind of re-engineer and hopefully ultimately simplify. That was the aspiration at the time. A rather complex and arcane revenue cycle process. And any of you have had to deal with a billing issue and calling, a hospital, whatever, it's generally less than satisfactory in terms of trying to figure that out, because it's complicated. And so we worked on that. We spent a lot of years just even looking at the technology. And I, learned a lot about technology. We had a great CIO, John Glasser, who was a thought leader, and learned a lot from him. And then we actually started to do the work. When we made the decision on the system, it was a Siemens product that they acquired a company in Pennsylvania. And the buzzword was, services-oriented architecture, which means it's open technology. It's almost like you have the internet And these technologies would consume rules from a payer system. So if you had a rule on if Rich Silveria goes to his PCP, does he need a referral? No, because that's his PCP. If Rich Silveria goes to this hospital, are they in network or out of network? So you would initialize the question. So, and it would expose it would basically, the payer would expose the rules and you'd consume them, and it would be as transformational as the internet itself. You didn't have to build all the rules in your system. That was the vision. And we went with this new Siemens project. So, we were taking, when I think about it, we were taking the business interruption risk, because billing and collections is complicated, and you might read in the paper every now and then a hospital's having problems because they went through a system conversion. You're taking the cultural kind of risk in terms of, just resistance to change is kind of human nature. But we were also taking the technology risk. So we were swinging for the fence. and the thought was, well, they're a $90 billion company. They've done 5 years of this. Let's see if we can leapfrog technologies, because most systems in healthcare have their genesis in the 60s and 70s, and that's still true. So ultimately, I worked on that actually part-time from 2002. We launched that program, and I think I signed the contract. It was a great experience. I signed the Siemens we had a co-development IP contract, a system implementation kind of business partner, Accenture contract. At the time, it was like a $265 million deal that I put together, which was a great experience for me. And then we got it live at Newton Wellesley, and that's where that ended. But just think about trying to, what we did is we got a bunch of executives together and say, is this worth it? Do we want to transform ourselves? At the time, we were losing money to bad debts and denials, and if we did it better, we could. So there was a business case. So we do whiteboard and visioning sessions, and then in terms of coming up with the corporate model, bringing people from Mass General, Brigham, North Shore, and trying to get perspectives on people and aligning on an approach. So it was probably one of the more challenging, but it was a lot of experience in terms of trying to make sure you're listening and aligning people, and being self-aware enough that you're, am I tired? Am I tuning out? Am I, and to me, that's kind of the key thing that I probably learned at Partners is, I always was self-aware, but I actually focused on it more and making sure that I managed myself so that I was receptive, because you got all these people coming at you with all these perspectives. It's easy, to get frustrated. But to try to thread the needle and get people to align on things. And, you never quite completely align. There's always nuance, or someone won't say what they really mean and they leave, and then later on you find out they're not on the table. It was a great change management project. We got the system technology up and running. At the end, though, after I left, that was still, I think it's still a great concept, but it couldn't scale to Partners. And so Partners actually pivoted towards Epic, which was what we're implementing now. But it was a Siemens Sorian product, which is still out there. Still a great vision, but it hasn't really quite been able to pull the vision off yet.
So a lot of kind of organizational change lessons from that. So this was not just revenue.
Yeah, so I built the business case. I did the contracts. I kind of did a vision. I did an alignment, and it was really it's almost like a startup company, Wow. But at the time, an $8 billion company when I was doing that. Yeah.
So after 12 years at Partners in 2010, you came here to Boston Medical Center, where we are today, to be the Senior Vice President for Finance and the System CFO.
Yeah.
Before we talk specifically about your role, tell me a little bit about Boston Medical Center.
Well, Boston Medical Center it's hard not to feel good about what Boston Medical Center does. It's the largest safety net hospital in New England. We serve the most, the underserved, so the people who are most vulnerable. And it's a noble mission. So, anytime it's work is called work for a reason, you work hard, and sometimes you have days where you come out and you say that was a, great day, and that was a great puzzle. And some days you're just gassed. You're tired. But when you think about what you do here and what you're doing for society, it gives you a lift. So, it's the largest trauma center, the largest safety net. We have 13 health centers. We have the largest interpretive services in New England. 30% of our patients don't speak English. More than half of them are at poverty. They're low income. We are 80% public payer, either Medicare, Medicaid, or we have a food pantry. We teach people how to cook. We have access to, it's more than an academic medical center. You have an acute illness, we make you better. We deal with really, in terms of Maslow's hierarchy of needs, really the basic human needs: food, shelter. We give prescriptions for food for kids who are failure to thrive, who have cognitive issues because of that, and we see them come along. It's, when you talk to the clinicians here, they're zealots about it. They're so impassioned about it. So it's a special place. It really is. Like anything, it's complicated. We are the teaching hospital for BU. So it's not partners, but it's got the complexities of partners. We have about $100 million of research. About 2/3 of that is NIH. We have almost 900 faculty. So there are physicians, but there are also faculty to be used. So the hospital is about $1 billion. The faculty practice plan is about $325 million. And we have a health plan with 300,000 members, about 75,000 of them are in New Hampshire. The balance of them are in Massachusetts, about 200,000 in Mass Health. And the balance of them are in the connector products. But they're also largely, indigent patients. And that is a $1.7, $1.8 billion. So altogether, we're about when you, in the accounting parlance, you eliminate revenues and expenses between each other, we're about a $2.9 billion company. So, third largest, once Leahy and BI come together, I think they'll be third, but we're the third largest system in the state.
So Boston Medical Center began as Boston City Hospital. Mm-hmm. Just curious, when did it move from a municipal to a? So it was
kind of in the backdrop of partners coming together in 1994. Mayor Menino at the time had envisioned a merger of Boston City Hospital with University Hospital, which was the teaching hospital for Boston University. And that was completed in 1996. So just 20 years ago, last year, we had our 20th anniversary. So it was, the first CEO, Elaine Yulian, I give her a ton of credit to pull it off. You have basically a city hospital with an academic medical center, and kind of grafting those two missions together. That they did already have a lot of kind of cross-pollination between, because they're so close, they're just a block apart. And Boston City, I'm told, we didn't work here then, was a great place to learn to be a doctor. So at one time, Boston City had over 2,000 beds. It had a teaching relationship with Tufts, Harvard, and BU. You fast forward later, I don't know when that stopped, but we're the teaching hospital for BU. So it was kind of in the same kind of context. Can you get scale, in terms of back office functions and negotiations with both suppliers and payers? Can you have more access to capital? And more access to network and covered lives. That's really the three fundamental reasons this consolidation, in my mind, is, scale in all contexts. It's a capital and labor-intensive business. You need capital. And ultimately, you need a network and covered lives, whether you're going to fulfill a fee-for-service mission or you're going to have enough top-line revenue in terms of premiums collected.
So you mentioned you have a network, Boston. It's referred to as Boston Health Net.
Yes.
And are these entities, you said 13 community health centers, are these entities part of BMC, or are they, how does the affiliation work? So
they're not corporately part of BMC. We have some unique relationships with some of them, and I'll describe in a moment if I don't confuse you too much by it. But so we have 13 members. Some of them are primary partners and secondary partners, and so we have different kind of gradations of relationships. And, and some of those relationships come with support from us. Community health centers are also financially vulnerable, like a city hospital. They rely on the government. And to be a federally qualified health center and to get those government payments, they, by law, have to remain independent. So we work with them. We have we do some direct support, and we work with them, put out specialists or primary care or family practice practitioners out there. And when they need acute care, they come here. We have a van that will shuttle them around the city. We have installed information systems. We just installed a web version of Epic into those health centers to give them access to health records, but also to try to manage that care within a system and have Epic be the electronic backbone upon which we execute a number of strategies. One of them would be population health. And again, if you're sharing information on problem lists, allergies, drugs that they're on, recent results, that's all part of the ecosystem. So, it's we about a third of our volume comes from our health center partnerships. We have an awful lot of, because we're a trauma center, a lot of emergency room visits. We're the largest emergency room in New England, largest and busiest.
In New England?
In New England.
Wow, okay.
130 roughly every year, 130,000 visits. So that's kind of probably the legacy of being a city hospital. But those relationships are very important to us. And as the state starts to pivot towards a population health framework where they want to move from every time you do a service, I pay you, called fee for service. And they want to put people on what we talked about in the PHO context. I'm going to pay you a budget, a premium, and you're going to live within that premium. And so we are actively working with the state as well as our health centers to say, well, how would we prepare for that? And because they manage those lives out there. So part of it is let's have a system and let's start having, infrastructure like increased behavioral health. Many times, much of the utilization is because of behavioral health and psych issues or substance abuse. Making investments in patient navigators so they know how to find their way around the system. So those are all things that we're doing to get ready for population health for the state, because the state right now has about 28% of its population on Medicaid, and it's heading towards 33%. So I don't think when we envisioned healthcare reform that a third of the state would be on Medicaid, but it's unsustainable. It's 40% of the budget. It does get matched, so 20% state money, 20% federal money, but that's still a big chunk, and it's crowding out other things. So we're actively working with the state and our CHC's constituents to try to deal with that societal issue right now.
So you also mentioned BMC HealthNet plan.
Yes.
And you said that you have beneficiaries who are in New Hampshire.
Yes. So we have Boston Medical Center HealthNet plan was initially the Massachusetts rendition of what they call an MCO, a Medicaid managed care organization. And they started in a Medicaid waiver that we filed to not follow all of the federal Medicaid rules, so you're waived from that. In 1997, we formed that health plan. It was largely a Medicaid health plan. When Governor Romney passed healthcare reform in 2006, we did the Massachusetts version of the exchange products, Connector. We had as much as 60,000 members in there. And then in 2014, if I got the date right, that's when you moved to the federal qualified health plan, which is the federal. And we've been growing. I think we're around 60,000 again there. In about 2012, we entered New Hampshire because New Hampshire wanted to do managed Medicaid. We thought that they were adjacent. And let's get some geographic diversification and not have all of your risk concentrated in one state and one product. And so we've been successful. We got the contract. We have about 75,000 members there. And we call ourselves WellSense in New Hampshire.
Okay.
Yeah.
I'm familiar with that product. All right.
Yeah.
So you are the CFO.
Yes.
Where do you fit into the organization of BMC? Who are your who are your colleagues at your level?
So I report to the CEO, Kate Walsh, who I knew at Partners. She was a COO at the Brigham, and she was also a VP at Mass General when I first started there. She reports to the chairman of the board. So, and then I'm also accountable. I have 4 committees that I run. Finance committee for the health system, with FPF, health plan, hospital, oversee all 3. And the investment committee and the audit committee. My colleagues are the other VPs, with the chief operating officer, chief nursing officer, chief HR. So we have Kate has about 6 or 7 VPs that report directly to her.
And how do you interact? Where do the lines get drawn between you and, say, the COO?
Well, the COO, he's also our strategy officer. I would say that he is coming up with what we should do in terms of the strategy. He's also trying to drive performance in terms of the operations. So in terms of the strategy, he comes up with the strategy, and then what I try to do is get the organization to perform at the level that we can fund that strategy, whether it be acquisition of buildings. So I try to get the balance sheet in shape to have enough capacity to buy a building or implement a computer system or whatever our tactics and strategies are. So in many ways, you have a long-term vision, and then you have kind of a strategic plan, which might be like 3 to 5 years. And then the budget, if you're doing it right, should be a one-year slice of what you're trying to achieve in your broader vision and your strategy. It's never that clean, because lots of times you look at, the state cuts money and you're like, I gotta get the budget in balance, and everyone's running around with their hair on fire. And we do that every summer because our fiscal year begins October 1. And it happens more here than maybe at Partners, because we are dealing with, the state, and the state really can't afford expansion. But I would say Alistair is, we get the budgets, we agree on what our objectives are, and then Alistair is the COO, Alistair Bell, he's a physician. He drives the organization to achieve that. And I kind of keep score in terms of, how do we do month to date, year to date, according to plan, make sure the audit financials are clean and I don't overstate income or anything like that. So the hygiene of it. But then also look at if you want to get that building, I said earlier, healthcare is both labor and capital intensive. Well, then I need to be able to throw dollars onto the balance sheet. So I have to have a certain income target so that I can accumulate enough retained earnings so that I have money in the bank, and then also debt capacity to be able to go out to the market and float some bonds. And so, basically the sources of income are your operations and your investment income, philanthropy, which is different, and, you can get that, your debt market. Sometimes you can monetize assets to get it. But basically, it's operating income, investment income, philanthropy, and debt. And then occasionally set. So that I basically set up a framework where you say, look at health plan, you have to perform here. Hospital, you have to plan here. Physician organization, you basically have to live within the envelope. They break even because they typically pay that out as comp. They don't have a balance sheet. And then look at the combined cash flows and income and say, okay, so I try to say, if you perform at this level, this is your optionality. If you perform at this level, this is your optionality. And so if you perform here, this is how much cash you have. What is your strategic priority with that cash? Is kind of how we lay that out.
Who reports to you? What functions support your effort?
So I kind of have the traditional, so I have the managed care finance, which negotiates the contracts, and that's kind of a group project because we have an ACO director and we have other constituents that we have the health plan, et cetera. The health plan CFO has some accountability to me, as I mentioned, because in the framework, although that person reports, like in Partners, to their CEO. Similarly, for the Faculty Practice Foundation, the finance lead reports to me as well as to that CEO. So kind of functional leads, or organizational leads, I should say. And functionally, I have treasury, accounting, reimbursements, budgets, supply chain. I said managed care. I have a chief of staff that helps me. I'm probably missing. Okay. I said reimbursement. So I have about 10 or 11 direct reports. I have financial systems area.
When you arrived in 2010, BMC was struggling.
Yeah.
You had significant losses projected. What was your role in the financial turnaround?
So, a part of a team, right? So you don't do anything on your own. I would say, when I looked at this opportunity, and Kate told me at the time, in the summer, I started here again in the end of 2010. In the summer, we started talking early in the summer, and then I finally accepted the job in October and started in December. But at the time, she said you might lose $177 million on $1 billion. And it was because the way that these safety net hospitals, Cambridge Health Alliance, and then BMC were funded through supplemental dollars. And so the theory was that, well, now we have universal coverage. Everyone has insurance. You don't need those supplemental dollars anymore.
What's a supplemental dollar?
So a supplemental dollar would be like almost like a grant from the government to make up for the shortfalls, because typically the way the financial ecosystem works in healthcare is public payers pay below cost, Medicare is closer to cost, than Medicaid, at least in Massachusetts and in most states. So Medicare might be 95% of the cost dollar, and Medicaid might be 65, 72 cents in that range. So you can't make it.
So and you're spending $1 and you're getting 68 cents back in compensation.
And the ecosystem in most places is Blue Cross, Aetna, Cigna, pay you enough margin, to cross-subsidize that. The parlance of healthcare, many times they say cost shift. I prefer cross-subsidize, but because I think it's more intuitive. But that's how it works. But we have 80%, either 44% Medicaid, 32% Medicare, self-pay free care pool HSN, which is somewhat reimbursed from the pool, but 80%, you can't on 20% have enough cross-subsidy, and we don't have the negotiation clout to even get good rates. So that's why you get a subsidy. So when I came in here, I'd never been a CFO before. So kind of like, am I ready for another rodeo like Lawrence? Because Lawrence was, so I was intrigued with, the mission. I thought it was noble. I really enjoyed my time. The people at Partners are great people, really smart people, fine organization. But I got to have my own investment committee, my own audit committee, my own finance committee, my own team, and can I turn it around?
Yeah.
And so when I got in here, we had FTI in here, which is like a turnaround company, and they at least had the playbook. I took the job in October thinking that it's October. Of course they passed their budget. So I took it. I said, look, I wouldn't mind going to a finance committee before I start in December. Can I come? And they said, sure, So I show up and they're passing their budget effective 10/1 in November. And I subsequently found out that was because, Ted Kennedy, God bless him, would occasionally get down there and find other subsidy money so you could make the budget. So they didn't work. The culture here was like, God will provide. But that framework had changed. Now it was really, you had some subsidy, but you had to bill and collect like everybody else.
Yeah.
And so I got there and they passed a budget for a $47 million loss. I thought, so over the summer they acquired $90 million of supplemental money, and we had to kind of make up the other, the rest of it, and through either reductions or top line growth. And we did over time. But we weren't there quite at that time. So we had passed a budget for $47 million, which included $32 million of improvements that FTI was going to try to get during the year. So you had a lot of execution risk. And $47 million was $15 million more than I could lose and not trip my bond covenants.
Okay.
So your bond covenants typically work at maximum allowable debt, maximum annual debt service. So the highest payment in your mortgage, if you will, right? And you have to have free cash, which is, your operating income plus depreciation and amortization has to be 110% of that maximum payment. I had to improve performance on top of the 32 that FTI by 15 to not trip my bonds. It's not that we would be bankrupt, but you'd lose control because your bond, then you have consultants come in and they take over. So
if you trip your bond covenants, you
lose. So in the parlance of a bond counsel, they call it the zone of insolvency.
Okay.
But it wasn't that we had a balance sheet. And I would tell Kate, look, it's not like we're not going to be in a payroll. We're just not going to be leading this, you and I. We're going to have consultants leading, right? Because the bondholders want to be represented.
Right.
And so, what I did then is I just tried to, I got in here so I just got to try to win every day. I mean, I can't think about the whole elephant. I got to just one bite at a time. And that's what I did. I had a similar approach that I had when I was, in my 20s, although it was a bigger job. It's just like try to think about what's the most impactful, critical thing. Focus on your relationships. It's a team sport. Try to get people to focus on it. Now, you come in here and it's kind of a scorched earth culture. We've had people laid off. Morale's not great. They didn't love FTI. People were fighting with FTI. I said, look, we want them to win. In fact, we want them to win even more than the $31 million. So I had to kind of get people kind of emotionally back because they felt like they've been just put upon and, reorganized and everything else. So we had targets. We looked at, things in accounts receivable, payer contracting rates, supply chain, labor, more than 60% of your business is labor. So really managing labor and flexing your budgets and vacancies, trying to, if you can kind of kick the can on hiring and get by. And we Kate Walsh's term, we grinded out yardage. And instead of losing 47, I think we lost 34.
Wow.
Yeah, or 32. So that was, fiscal year 2011.
Yeah.
And then, by fiscal year 2012, we had a $800 operating gain.
$800
on a billion.
Not that. Okay. That's a thin margin.
It's a very thin margin. Yeah, you wouldn't say have venture capitalists come in here and say, I want to put billions of dollars in this bricks and mortar, and I hope it throws off $800 a year. But that's the difference about, that's healthcare mission, and that's city hospital kind of, you're doing God's work. So you would never build this place based on a return on assets. But anyway, so, and we've been in the black ever since. So it's, I'm not telling you it's easy. You can never let your guard down here, and you're always looking at the next, because it's really, as you expand coverage, it's really the affordability. I mean, I think we figured out how to give people insurance. I don't think we figured out how to afford it.
Yeah.
And we're in the riptide on that because we've got so many subsidized patients.
So what's a day in the life of Rich Silveria like these days? What kind of consumes most of your time?
So I was thinking about that because I saw your questions earlier. So I'll just tell you what I'm working on now. So we finished the Epic clinical system implementation. We did that in 2 tranches. We did inpatient largely and then outpatient. We finished that in 2015. We took a year kind of to optimize it. Now I'm looking at revenue cycle. So registration, scheduling, charge capture, billing for the hospital physicians and everything, research, clinical studies. We're in the middle of that project. That's a $66 million project. So I'm the executive sponsor of that. Major transformation, major process change, governance, et cetera. So, back in the saddle on that. Probably going to be going into the bond market. This will be the 5th time I'm in the bond market because we're looking at some potential investments to continue growth. So that's a fair amount of work. You have to, you have to use bond counsel. You have to write what they call an Appendix A, which kind of lays out your organization, its leadership team, its market share, its strategies, et cetera. Meet with the rating agencies like Moody's and Standard & Poor's and investors. So that's a major endeavor. We're changing in supply chain. We're changing our distributor, the truck that backs up.
Yeah.
So you have to get new SKUs, all that, par levels. So we're in the middle of that. That will go live in April. I'm in the planning stages of a major upgrade for our GL account. It's Lawson. And that's basically a rewrite of the operating system, a database restructuring, and application. So it's like almost a reinstall. So that's coming. We're doing a BI tool for revenue cycle, trying to get more data cubes in BI and pushing analytics out to the front desk in terms of cash collections and denials, et cetera. So it's a web-based tool. And then there's just kind of the day-to-day. I've got running payroll and AP, and there's just a lot going on here. The other, probably the biggest omission I had is we're getting ready for population health for 44% of our business, Medicaid. So what's the funds flow process for that? How do I have enough risk-based capital to assume risk? The other thing that's going on is every year I have a cadence of I do a multi-year. I think I described it somewhat earlier. I do like a 3-year projection. It's hard. We used to do it 5 in partners, but with the vagaries of the public funding, I think after 3 years it's really hard to anticipate what's going to happen in 5. So we do it in 3. And so we forecasted for the health plan, the faculty practice plan of the hospital, get the earnings targets, look at the balance sheet, and say how much can I go to prepare for the board to say, do we make these investments or not? So that's it's a lot going on. I could go on, but that's kind of what's going on. It is a lot. Yeah.
So as the CFO of a nearly $3 billion health facility, what keeps you up at night? When you're laying in bed, staring at the ceiling, and you're thinking about work, what is it that's running through your head?
It's a few things. I guess one is just there's a lot going on, and it's almost like the magic trick where you're spinning the plates, and you're on that one, or is it starting to wobble? So it's just trying to keep all the balls in the air of the plate spin, whatever metaphor you want to use. So there's some of that. There's a lot of healthcare is at a time of great change as you move from fee for service to accountable care. So that's probably much of it. But then it really is, as I mentioned, it's capital and labor intensive. And will we have enough scale as BMC, even though we're $3 billion? Will we have enough scale as the market continues to consolidate? You've got Beth Israel and Leahy now, and you've got partners, and you're doing arguably God's work here. But we're a single provider play. What's the future for a single provider safety net hospital? And it's not that I think that everyone in this city wants to see us succeed because we play such an important role for this ecosystem in the city. But on the other hand, it's not like we're actively being pursued in any type of M&A context, merger and acquisition, because of the vulnerability that we present to anybody who would the state or the federal government walk away from their supplemental payments and say, well, now that's partner's problem. Well, partner's probably too big now to acquire us anyways. But so that's part of it. But earlier I said a third of the population's in Medicaid. So we're not a marginal player here. But it's not the book of business that is going to be able to keep you clinically relevant and be able to innovate with that kind of payer mix. So it's a complicated time. I think we're as well positioned as anybody because we have both the financing and the delivery to be able to assume risk. We have a health plan with risk-based capital, and we have a local ecosystem here. So in this section of the world, and then we start to use our health plan to gain scale in lives with this network. So it's not the typical M&A, I'm going to buy a bunch of hospitals to get enough lives. It's more a contractual network. So that's an avenue for us. But there's a lot going on. You've got a new president too, who, may repeal and replace. Certainly says it. The AC. What does that mean? So there's lots of uncertainty. I guess that's probably, in a word, what keeps almost probably anybody awake in healthcare is uncertainty.
Okay. So, reflecting on your career a bit, were you ever tempted to take your finance skills and jump out of healthcare into something completely different?
I've thought about it, but that's about as far as I ever got.
Yeah, okay.
I thought of many times, like I've done so much systems work, and I was at one time, well, my skills are gone compared to what people are writing in Java and C++, and I was in Pascal and COBOL and really ancient languages. But could I create a tool that would be relevant that I could sell, or would I work for an IT firm? Every now and then I think of that. I've also thought about consulting potentially, because I like to teach and I like to think about what are the thought leaders doing and try to keep yourself fresh. But not really seriously, I would say.
How has healthcare finance evolved over your career? How is it different today than it was back when you started? What are the most significant aspects?
I would say that I think finance was kind of a back office function. Just close the books, you stay in the basement of the place and let me know how we did. And I think some of it's still that, but I think what healthcare providers are looking for now is somebody who can actually think not about just the regulatory framework, cost reports, or accounting rules, but help me think through the business implications of these strategic decisions.
Yeah.
And can you be a strategic partner with me?
So it's much more strategic than it was.
I would say it is, and it's increasingly becoming that. And I can't say that in every context because every CEO has their own style.
Okay.
But it's definitely more strategic than it's been in the past. It can be a lonely job too, though. I will just, there's people going, it's hard to drive change and be loved sometimes when you try and turn a place around. And when you have a budget crisis and you're talking about, it's like, you end up kind of Chicken Little, right? The sky is falling and you always, it's not always the most inspirational speech you have to give, but, all you can do is just try to guide the organization and be respected for what you do. But it's not always, as you get into it, you have to think that part of it through. And you don't really get that until you really get to the top and you start to see what that life is like when you're trying to work with your colleagues who are very bright, many of them brilliant people. You don't come up with bad ideas from VPs. The problem is you don't either have the bandwidth or the resources to execute them on, and then you have to decide, well, what are my priorities? And that's always a negotiation, and it can be, there can be rubs.
Actually, that ties into kind of my next question for you, which was, what do most people within healthcare but outside of finance not understand about finance? I mean, what do you find yourself educating your VPs out there about most often?
I think in some cases not all of them are, they're not quantitative, and sometimes they don't really understand the value of it, or they might have a notion that you're here to just cut my budget, or you're just a harsh person and always negative, and you're not really here to help me.
You're just a bean counter?
You're just a bean counter. You're just a bean counter, or here you are, doom and gloom again, and lo and behold, we're fine by the end of the year. And sometimes, that happens, but you see the storm clouds, it doesn't always rain. But, I think it's that you can actually think on an operational level, that you can think on a strategic level, that you're not just one or two dimensional individual, that I'm a leader, but I just happen to be focused in finance, and that's where and that's what you hopefully convey, and and that you can think outside of just like it's too risky, we're just going to say no because no is the safest thing. Can you also say yes?
Yeah.
And I think that's what you have to kind of convey to people, that you are willing to, and that you're actually in a business that has a mission that isn't always a 15 or 20% EBITDA. You're going to have, but you have to have a portfolio of mission, which might be break even or losers, with some things that are accretive to your mission in terms of financing, so that it all hangs together. And people want what they want.
Yeah.
And sometimes you just have to figure out, well, how can I talk to people like, what's important to you? Well, let me tell you what's important to me, and let's see if we can't find some common ground.
I'd like to transition and ask you a few questions about leadership. You've told me a little bit about kind of your style already, but I wanted to ask you, could you encapsulate your leadership philosophy? What would that be?
I believe in leveraging the collective wisdom of people around you. To me, I love to learn. I love to be asked. I am energized with learning. I love to learn. And I love to surround myself with people who love to learn. And it's really, if you're going to have somebody who hoards information or whatever, that doesn't really fit with me. So I find I get energy that way. I find people who I like to surround myself get energy that way. And you're constantly thinking, and you're always like, you might have a notion of how you're going to do something, and then you're like, oh, that was a nugget. I'm going to incorporate that slightly into my approach and make it even better. So I would say kind of democracy in the generation of solutions and ideas, but not necessarily always in decision making, because I have to make the decision ultimately.
Yeah.
But I don't delude myself to think that I know everything, because I don't. And I'm glad I don't, because I like to learn. And so that's, and then I try to model what I want to see. I want you to be forthright with me. I don't expect you to always agree with me. I'm going to respect you. I'm going to tell you what I don't agree with, but I'm going to do it in a respectful way, and I expect that to be reciprocated. So, I think culture and leadership is something that you just can't say, we're going to go to this seminar and we're going to have this inspirational moment and we're going to go back and everything's going to be different. That's not my experience. My experience is just like day to day, kind of demonstrating, that you're a person of your word. You engage people. You try to get them to engage with you, share ideas, and that you are trustworthy and they're trustworthy, and then that's how it's over time. And if you kind of, and you manage yourself, I don't want to be the type of person that's like, well, boss is here. What kind of mood are they in today, right? To me, it's most important. It's like, there's a moment between stimulus and response, right? And so I've done a lot of self-help kinds of books. I just like learning about different perspectives, whether it be Tony Robbins or Stephen Curry or whatever. And you always like, okay, look inward first. And then what am I focusing on and what's the outward manifestation of what I'm focusing on in my behavior or whatever, and try to make sure you're in the moment, you're hearing people. If you were perfect, you'd be doing that all the time, but you're not. You're a human being. You get tired and you have vulnerabilities and frailties. But that's what I try to do is I try not to be, I'm generally not a moody person. And I try to notice when I'm tired and gonna be moody and withdraw.
Yeah.
And I exercise regularly because I need to get the stress out. So at least 4 times a week, during the summer on my bike or I'm on my stationary bike, and I find that really helps me. So that's how, I think managing yourself at the executive level and being self-aware is what you need as an executive, is to manage your emotions and interpret things, and then, not react and have outbursts but then having the courage, if you couldn't do it in the moment, because not everyone's brilliant in the moment or it's too risky, till later go back and talk to somebody describe the situation, what the issue was with the situation, and how it either you interpreted or how you feel, or the problem that would create for your role or whatever, and why. And so I interpret, tell me your side. And this is what I need, and this is what you need. Because lots of times you make inferences from people's behavior, you make assumptions, and all of a sudden you've made judgments on people and their motivations, and you have to test that. And you have to have but like anything, there's some people you're going to have an affinity to and you're going to gel. There's some people you're not going to have that, but you have to figure out how to work with them, and you have to respect each other. And so that's a rambling answer, but I think it's managing yourself, and I think it's treating people the way you want to be treated. And to me, it's about harnessing the brain power of everybody.
When you're hiring leaders, what do you look for?
Desire.
Okay.
I look for desire.
What does that mean?
To me, it's like if you want to succeed,
yeah,
you generally do.
Okay. So you're looking for some fire?
I'm looking for fire. I mean, you can have the greatest resume, but like if you're not going to do anything. So I look for baseline experience.
Yeah.
But I look for somebody that I think that has the hunger to do it. That when I ask them, talk to me about the behavioral interviewing technique. So talk to me about a time that you had a boss that you had to kind of convince to do something else, that you had a point of view and they weren't there. Tell me, did you ever have that? Tell me what you did.
Yeah.
What was your approach?
Yeah.
Talk to me about a time you had to work with somebody that wouldn't work with you. What'd you do? Well, you ever have that? Well, what would you do? And try to get the behavioral part of it, because I find that intelligence is multi-layered. There's content intelligence but I think when you get to the higher levels, it's more about that and can I work through people? Will people follow me?
So you're looking for people that can work through people.
Work through people, and then and can they lead them, and can they influence? And particularly in academic medical centers, there's often blurry lines of responsibility, and you can't control everything, even though your job might be graded on some things that happen in other areas. So you have to learn how to influence people and to try to how do you coax, cajole, how do you influence? And to me, it's baseline knowledge and desire, and then it's can they describe how they have a point of view and how they drive and influence.
So I'm going to throw a behavioral interviewing question at you. So can you give me an example of a difficult leadership lesson that you had to learn the hard way?
Yeah, a couple, sadly. But
we all do eventually.
Yeah. I guess in some cases, I am such a mechanic sometimes. You mentioned I'm in the weeds. Yeah. And I know what you have to do. I've done it before. So like if I'm implementing a computer system or whatever I'm doing, and I get locked and loaded on the job and trying to get it done, and maybe not the context of the job. And you might underweight the politics or the collateral damage of the relationships if you're saying, look, I can't let this fail. It's accounts receivable or it's payroll. And even though you're right, technically someone come and get an auditor in there, yep, you were right. You didn't have enough the blinders are on so much that you didn't have the lens opened up enough to let in all the light.
Yeah.
And so that's something that, and that's probably you're tired or you're under duress or whatever. So, you also have to make sure you're paying attention. Sometimes you're in a crisis, you tend to focus on just the issue at hand, and maybe not enough of the relationships around you, and you get yourself into some hot water here and there. And, it's happened. And if I could do it again, I'd do it over, and I've done it differently. I would have been a little bit more receptive or listening, but it's usually reciprocal. Anytime those situations happens, there's more than one set of handprints fingerprints at the crime scene. It's contributory.
I like that. That's true.
Yeah.
So I want to ask you that if you could go back in time, kind of to the early part of your career, and talk to your 20-something self, what would you tell him? What advice would you give him for the future?
I would probably tell that younger person to listen more, to be more confident too, not be afraid to, because it takes a while to have enough courage to say something in a professional way that's not going to be like, oh, you're the best, or you have to give a hard message to listen, and then to also learn as quick as you can to set those boundaries. I did over time, but it took me a little while to get there. And it's okay. And people will respect you. Because, I think all of us, to some degree, have this incredible desire to be liked.
Yeah, sure.
You're right? Everyone.
It's a powerful drive. Yeah.
Right. And you can still be liked.
Yeah.
It might not be the like to you say, it might be more respect and like. But hopefully maybe you'll be like, then respect them, and you like even more because they see how you behave. So it's really, listen to people more. Don't be thinking about, ask them what they want. Because, 94% of the time, I had a executive coach, 94% of the time you're thinking about, am I hungry? Am I tired? What's going on with my kid? You're thinking about your inner orbit. 6% of the time you're thinking about other people, right? And so recognize that in yourself, and then recognize your person is there, and then ask them what's important to you. So I guess, becoming more self-aware younger, that's like the key lesson. That's probably really, I learned how to work and be collegial and drive people at Lawrence. It was much more complicated, and I had so many constituents, and I had to manage myself more at Partners. And if I could learn that younger, I probably would be, even more effective. And I might have had some of those situations I just described to you where, I wasn't quite on my A game.
Did you have a mentor or mentors that played a significant role in your development?
Not directly, I would say.
Okay.
I watched people.
Yeah.
So my boss, probably the closest I would have was Peter Markell at Partners, but it wasn't like I'd call him and say, hey, I got this situation. Can you talk to me about it? But he would give me advice when I would tell him, it wasn't always in that, but I would watch how he or other, I mentioned John Glasser. I would watch the way he would navigate. He was a great speaker. He was funny. And then so you pick up a few tricks from it was like a junk collector, picking up things along the way and incorporating it into your repertoire. Or you'd watch somebody, handle something badly or something well and say, well, don't do it that way, and do it this way. So I tried to watch other managers. I did have a couple of directors at the time, because I was manager or analyst level, that said some things to me that were impactful, like get an A in your job. Yeah. It's easier to beg for forgiveness than ask for permission. One of the CEOs at Choate Sims told me that, and I said, that's good as long as you're right. But I generally had a good instinct of when I could do that and what calibrating the risk. And then, of course, you got teachers and professors and your parents and everything else that pick up. My dad worked really hard. My mom did too, and my dad had a good sense of humor, and so you incorporate that. So you're kind of the summation of your experiences. But I can't necessarily say this one individual, but it's great if you can. I've done it.
Okay. So what do you think a good mentor does?
I think a good mentor tries to say, well, if you thought about it this way, you try to network, et cetera, just do this, go to school here, should you take this job? Kind of advice. Yeah. But a good mentor will also tell them when, look, I'm going to give you some brutal feedback here. Yeah. I don't think you've put enough into it. You're expecting to be at this level, but talk to me like what have you done to do that? And so, okay, and it's almost like you got a coach who will someday say, okay, all right, in 5 years, you're whatever, you're the director of this function, or you got this, this achievement in your work. Now write the story how you got there, right? You've heard that, okay, right? Yep. So I would, you're here, but tell me what you did. Tell me the story you did to get there and why you think you're there. And so that's sometimes important, because I think lots of times when you're kids, you grow up, everyone gets a trophy and everything else, right? Life isn't that fair all the time,
right?
And it's much more discerning.
So you're a member of the Healthcare Financial Management Association, professional association we talked about. Mm-hmm. How important has that been to your career? I think it's probably pretty important, since that's how you got your partner's job.
Well, that's how I got recognized. Yeah, I mean, it was just. I mean, I was on committees and things. Part of it was like I got a lot out of it just because. Well, one, as I enjoyed people and I enjoyed the collegiality of meeting people every now and then. At the meetings, I love to learn. And I didn't mind public speaking because of my teaching background and everything. And like anything, you have to talk to yourself and make sure you don't let anxiety get away from you when you're about to get in front of a few hundred people. But I generally like it because I like to learn. And I think, it's just a great way to exchange ideas, create, collegial relationships that, you can call Mary or you can call Bob or whoever and say, hey, if you run into this, can you, this reg just came out and we're all reading it at the same time. This is how I see it. What do you see? And it's just that, cross-pollination and sharing of ideas and collegiality is invaluable. And then you never know. I mean, you might make a connection and someone say, hey, I'm looking for something, and it might help you with your career. I think it inevitably will. So I think it's good to get involved, and plus, it gets you closer with the thought leaders, and you keep yourself fresh.
So I have a personal ask. So I teach the finance and accounting sequence in our program. Yeah. So what are the most important skills that I should be focusing on for my students as I prepare them to be, to enter the workforce as early career healthcare administrators and so forth?
Well, one is I think they need the basics, which I think you're doing. This is a P&L, this is revenues, expense, and this is your balance sheet, and this is your owner's equity, etc. But what I think if you could teach them a little bit about things that are non-cash and what like a free cash flow really is, because you might say you lost $5 million from operations, but I threw off $90 million in free cash. How did that happen? Well, you had $15 million in amortization costs, and you had $90 million in depreciation. Those aren't cash, right? So if you're running a business and you say, well, how am I going to make this? And should I look at a business from a operating margin perspective, or should I look at it from an EBITDA perspective? And how do I, and then how do you cover your bonds and those kinds of things? I think a lot of your students, I suspect, are going to be in healthcare and maybe, not-for-profit.
Yeah.
And maybe a little bit about quality of earnings. So I made $20 million this year. My allowance for doubtful accounts was $40 million last year, and it happens to be $23 million this year. What happened? Well, I actually pulled my reserve through my P&L and said I didn't need it, right? Is that okay? Why do you believe that? So, like, changes in balance sheet reserves can be flown. So if I wanted to say, well, I made this, or I had a one-time rebate from a manufacturer, or I lost money, but I refinanced my bonds and I had, defeasance costs and advanced refinancing costs. And so that's not in the runway. So it's more than just, debit, credit, and, which side of the T account you're on. Because if they're not accountants, they're going to forget that. But it's more about, how do I read it? And if I'm a business person and I want to drive change, how do I know that this is a going concern? And how would I evaluate, if I want to look at it, that potentially the quality of earnings is either understated because it's one time or overstated?
Yeah.
I think then you really understand it kind of almost conceptually and intuitively, like what's important to look at. I don't know if that...
No, that's great. So last question. For a young person thinking about a career in health, why should they think about healthcare financial management?
first of all, I think there are people who, I've seen them, they're CFOs, they become COOs, they become CEOs. So it's possible to go, right, you're in the C-suite, so you're close to the action. You are very much the right-hand person or the left-hand, one of the COO and the CFO are kind of driving the show, right? And so you're right at the board. You're right at the nexus of the business. So it can be from that perspective. You're thinking about, I have to drive performance, or I have to form capital so we can get this new Liniac for cancer care, or whatever it is. So that's, I think, if you want to be in a role that's impactful, and you're right at the confluence of strategy and operations and everything else, it's just a great place to be. It's a lot of work, though. I mean, I will say it's a lot of work. And like I said earlier, you got to let things roll off you on a number of levels. One is, people are not always going to be happy that you have to make allocation decisions on resources. The other is you can't be up every night, and you just gotta, on the weekends, you gotta try to put all these things that are on your mind in a place, and just try to relax and enjoy your family or whatever's important to you, and try to do a few things that you can kind of just, whatever that is, whether it's reading or biking or whatever it is, just to kind of put your mind at ease and get into a place where it's not on you all the time. So, but I think it's a great job. Yeah, I think CEO might even be more fun. Yeah. But I look at that, and that's not without its warts either, because not only you're the CEO, but you got to deal with all the docs, and you've got to deal with all the community. So at least I can kind of go home more than Kate Walsh, who has to go to the mayor's thing or the governors or whatever, and deal with philanthropy and everything else. And so that's, but it's intriguing when you think about, trying to position your organization for success in the CEO job would be also, I think, very challenging. But there's like any job, has things that you're going to love, and there's going to be things that you don't love as much. But but I would say it's a great job, and if you want to be impactful to an organization, and it's a very generally it's a very respected job, and people know what you do, and if you can kind of keep place in the black and manage through it, you do earn respect of your colleagues.
Well, thank you so much for your time today. I appreciate this.
It was my pleasure. I enjoyed it very much. Thank you.
You've been listening to the Health Leader Forge, a joint production of the College of Health and Human Services at the University of New Hampshire and the Northern New England Association of Healthcare Executives. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again in about 2 weeks.